Hi, my name is Jeremy Moore, and I've been asked to debate the topic of Brockenbrough is superior to magnetic navigation for complex ablation and congenital heart disease, and I'm taking the pro position here. I have no disclosures. So just to start off, I want to just point out that at UCLA, where I practice, we do have a remote magnetic navigation system, and I've used it before, so I understand the sort of the implications of this system and how it works. But I still believe that the manual ablation, the Brockenbrough approach, is superior. These are the proposed advantages of the two approaches. For remote magnetic navigation, proposed advantages include additional catheter stability for very large chamber sizes, the ability to circumnavigate vascular obstruction and anomalies, to avoid having to cross baffles, conduits, and prosthetic material, reduce radiation exposure, improved ergonomics, and convenience. For manual ablation, or the Brockenbrough approach, we have advantages that include multipolar mapping, direct quantitative force measurement, better lesion size and durability, advanced energy sources, greater system availability, the ability to do single shot PVI, additional catheter control in certain situations, and a proven track record. So we'll go through all of these the two sides today. So catheter stability, if you look at remote magnetic navigation, basically you have two large magnets that are placed on either side of the patient, and these magnets can control the catheter tip as it circumnavigates through the different chambers of the heart. And you see these nice videos where it looks like a snake traveling through these little rings, getting to the ultimate target. So you do have great catheter control, but, and I think even when it comes to large chambers and situations where you think catheter control would be difficult, with manual ablation, I think the experienced operator gets good at picking the right catheters, the right steerable sheaths, and learns ways to control the catheter stability so that even with these giant right atria associated with the atrial pulmonary fontana shown here, we can get high density maps, do a great job with our lesion, with our mapping and our lesion delivery, and we really don't have any trouble with catheter stability. Here's an example now. The second issue is vascular obstruction and anomalies. This is a patient who had lateral tunnel fontan with a mechanical mitral valve, and you can see here the femoral veins are completely occluded. So one would think, okay, we'll just use remote magnetic navigation, but with the mechanical mitral valve, you can't get into the pulmonary venous chamber. So what we've done is we've gotten quite good at puncture procedures. We map the lateral tunnel fontan retrograde, and we do a transhepatic puncture to get in to do the transeptal baffle puncture, the transbaffle puncture, and we find a reentrant circuit in the pulmonary venous atrium that we're able to map and ablate successfully. And without this ability to do the Brockenbrough approach in a complex situation like this, really we would not be able to get to this circuit any other way, including remote magnetic navigation. What about standard baffles and patches and prosthetic material? Well, again, for mustard patients in general and other types of baffle procedures, we've gotten very good at crossing through these baffles using typically a combination of angiography and ice to visualize the puncture site. And we found very complex arrhythmia circuits in these patients that really support the direct approach so that we can really elucidate the catheter, the tachycardia mechanisms more fully and get a better result, as I'll talk about a little bit later. In terms of extracardiac fontans, we've had a multi-center study showing that we can get through these conduits safely and without complication. And we've shown not only that, but we can actually get larger sheaths across for single shot PVI, say in fontan patients, extracardiac fontan patients that have atrial fibrillation, as shown here, which really shows us that we can get to these areas without too much trouble using the standard Brockenbrough approach. This is a study now from our own center, 10 years worth of what we call a transcaval puncture approach. This is where we puncture below the extracardiac conduit, where there's oftentimes a region of overlap between the IVC and the pulmonary venous atrial wall. And we found that in most cases, we're able to do this. This feels a lot like a standard transeptal puncture. And we're able to get directly into the pulmonary venous atrium for direct mapping and ablation using this type of approach, which is actually more common than one might otherwise suspect. What about radiation exposure? I think proponents of remote magnetic navigation point to some of the data like this one here, where we see that as you get from group A to group C, where we're typically relying more on remote magnetic navigation, the duration of fluoroscopy goes down and the dose of radiation goes down. And so you would think, okay, that remote magnetic navigation is better than the standard approach in terms of radiation exposure. But if you look at the most recent data out of, this is the study out of Akron, Ohio, a multi-center study looking at 3D mapping in complex congenital heart disease, you see that the radiation exposure here is in line with what you see with those remote magnetic navigation studies. And in fact, only 23% of patients required any fluoroscopy in complex congenital heart disease. So really radiation exposure is not so much of an issue these days. What about the ergonomics of it all? Well, proponents of remote magnetic navigation say, well, you don't have to put on lead. You have a better. This is better for your back over time, and has some real advantages for the physician. But if you look at a standard remote magnetic navigation case, this is one where the attending is sitting here, kind of slouching on the chair. You have the fellow standing in the back taking pictures and standing with their lead on. Now, who has better posture? Well, you'd argue that perhaps the fellows here, wearing their lead, have better posture than this attending, and not necessarily any better in terms of ergonomics, the way this person is sitting. The one advantage, I think, would be that he does have his cup of coffee readily available, and he can be sipping on that in between his mapping maneuvers. So that's the real advantage here. Direct force measure. Now getting to the advantages of manual mapping, the Brockenbrough approach. We have better catheters. We can utilize these to get precise measurements of the contact force. And all of the companies out that provide catheters these days have proprietary algorithms for force sensing, and including this local impedance measurement with direct sense on the end there, that are really invaluable resources for not only measuring contact, but also lesion delivery and the effect on the tissue itself. If you look at what's available with remote magnetic navigation, I think my opponent will tell you that he can measure contact force. However, that's not really true. There's an indirect assessment of tip impedance, which is a generator impedance, not very accurate. It assesses catheter motion, but that again is going to depend on, doesn't tell you tip pressure, it just tells you whether the catheter is moving. And then magnetic torque, which can be misled by the way the catheter is sitting in the heart. So none of these are ideal, and this is not direct pressure measurement. This is indirect assessment of stability and impedance, which are not, again, direct measurements of contact force. We know that these direct measurements do improve outcomes. This has been shown in the atrial fibrillation literature, and I think it's applicable also to congenital heart disease, where we know that good contact results in better lesion formation. With respect to lesion formation, we know that low pressure, such as low force, such as 6 grams and below, results in fairly small lesion sizes. When you get to 20 grams, we get a significantly larger lesion than those with the low force lesions. And I think this is really important, because if you look at remote magnetic navigation and how much pressure is measured with the tip, and this has been performed by my opponent today, with the catheter placed into the heart and against a chamber wall, you get around 5 to 6 grams of force. He will say that with putting the sheath up against into the entry of the chamber of interest and then putting the catheter against the wall, you can get up to 20 grams of force. However, oftentimes we don't get that luxury when we're doing these complex congenital cases. We can't get our sheath to go through the aorta, into the ventricle, back through the mitral valve, and into the pulmonary venous chambers. So we're really giving low force lesions a lot of times in congenital heart disease with remote magnetic navigation. And so I think that's an important consideration. The next major advantage of manual ablation is the multipolar mapping catheters and the ultra high density, ultra high definition mapping catheters that are available, as opposed to the simple point-by-point catheters that are available with remote magnetic navigation. And with this high density mapping, we know that outcomes can improve. This is our study of bi-atrial tachycardias that we found the identification of bi-atrial tachycardias was closely associated with the mapping technology. And as we went from point by point to multipolar mapping to ultra high definition mapping, our yield on discovering these complex arrhythmia circuits significantly increased. And so there's clearly advantages to multipolar mapping in congenital heart disease. These are a couple of cases from our institution just actually over the last few months of bi-atrial reentry in a mustard patient and bi-atrial reentry in a lateral tunnel Fontan patient, where high definition mapping really showed us exactly where we needed to go to perform successful catheter ablation, and we were able to eliminate these tachycardias with a small number of lesions. We also know that these ultra high definition mapping systems include algorithms that are able to localize critical isthmuses with a high degree of precision. And when you look at the characteristics of the conduction isthmuses, they correlate with these algorithms very, very closely. And we can then use that to our advantages to quickly localize the best locations for catheter ablation using these systems. And finally, complex reentry is becoming increasingly common in congenital heart disease, especially when we're talking about left atrial pulmonary venous circuits. Oftentimes there are complex reentries related to the coronary sinus musculature, the ligament of Marshall, and we're finding that these circuits are very complex. And really, the high definition mapping allows us to figure out exactly where to perform our ablation lesions, which we can't do with point-by-point mapping associated with remote magnetic navigation. Finally, we have advances in energy delivery, such as cryoballoon ablation, pulse field ablation, and dual RF pulmonary pulse field ablation. Catheters already exist or are coming very soon, and these again are only going to be available with manual ablation and not with remote magnetic navigation. And I'm really personally excited about this because we know that we can achieve better outcomes with these advances in ablation technology. We've shown that single shot PVI with cryoballoon and CHD is very effective. In fact, it's equally effective as in the general population with acquired heart disease. We have new catheters on the horizon, multipolar ablation catheters. We can do linear lesion sets using pulse field ablation. This is going to be a safe way to ablate in certain areas of the heart and much more time effective to provide durable lesions. And I think this will be applicable to congenital heart disease. Finally, catheter management is a basic concept. It's very important. So if we want to use ICE catheter while we're doing our ablation, for instance, it's good to be able to stand at the patient's bed table and move the ICE catheter as we're moving our ablation catheter, which we can't do, obviously, if we're sitting in the control room. There's also limitations in availability. This is a major limitation of remote magnetic navigation. We have numerous sites across the North America that are performing catheter ablation in congenital heart disease, but only a very small proportion of these actually have remote magnetic navigation due to the almost prohibitive cost of these systems in many hospitals long term. Finally, evidence in congenital heart disease, I think, is a major advantage of manual ablation. We have very, very good data from our center, for instance, where we have almost 300 ablations in 250 congenital heart disease patients, many of whom had very complex situations involving baffle puncture, extracardiac Fontan ablation, and we are able to achieve very good results over time, approaching 84% freedom from recurrence in this population over 5 years using our standard manual approach. On the other hand, we have the largest study to date in using remote magnetic navigation is only 94 patients, And because of this small number of patients that have been studied using this system, these systems really carry a weak Class 2B indication for catheter ablation and congenital heart disease. So to summarize, I think the advantages of remote magnetic navigation are questionable at best. I think catheter stability we can achieve with manual ablation and the puncture approach. Vascular obstruction anomalies, I think we can circumvent again with manual approach, and in some cases it's better to use the manual approach, as I have demonstrated. Baffles, conduits, and prosthetic material are really not that much of an issue, and we can get around these again with the manual approach. Radiation exposure, essentially, I think I've shown that is pretty equivalent between the two. Ergonomics, perhaps there's some advantage there, although I'm not sure it's always utilized. And there's some convenience, obviously, to remote magnetic navigation. The advantage of manual ablation, however, are significant. We have multipolar mapping. We have direct force measurement available. We can achieve better lesion size and durability. There's greater system availability across the country and across other countries as well. We have emerging ablation technologies that I think we can be utilized in congenital heart disease. And we have a very established track record in congenital heart disease for this. So clearly the advantages of manual ablation and the Brockenbrough approach are superior to those associated with remote magnetic navigation. And finally, I feel like sometimes thinking about the fact that remote magnetic navigation may be trying to solve a problem that's really not there, maybe creating its own unique issues in the process. There's the old adage that if it ain't broke, then why fix it? And I think that applies to congenital heart disease, where we have a very good approach in terms of manual ablation, and really remote magnetic navigation may not be solving any real problem here. So with that, I'd like to thank everybody for their attention, and feel free to reach out to me if you have any questions. Thank you.